Chronic obstructive pulmonary disease, or COPD, is a constant presence on the medical landscape and a significant topic for any nursing student preparing for the NCLEX. It is a condition that, once it takes hold, rarely lets go, casting a long shadow over a patient's life. Understanding its nuances is not just about passing an exam, it is about providing compassionate, effective care to millions. This lesson will demystify COPD by breaking it into manageable concepts, its causes, its effects on the body, and the crucial role nurses play in managing its progression. COPD is a long-term progressive lung disease characterized by persistent airflow limitation. Airflow is obstructed by inflammation and structural damage that worsen over time. The hallmark symptoms are shortness of breath and a chronic cough. COPD is an umbrella term for two often overlapping conditions: emphysema and chronic bronchitis. Each damages the respiratory system differently. COPD is chronic, non-reversible airway obstruction with progressive decline. Unlike asthma, the limitation is largely fixed. Spirometry confirms obstruction. It forces the body to work harder just to breathe, with impacts on the heart, muscles, and overall well-being. Emphysema is a problem of destruction at the microscopic level. The alveoli are damaged and lose elasticity. Like an overstretched rubber band, alveoli fail to recoil, walls disintegrate, small sacs merge into large, ineffective spaces. Gas exchange surface area plummets, causing hypoxemia and hypercapnia. Loss of elastic recoil lets small airways collapse during exhalation, air trapping. Chronic hyperinflation develops, often with a rounded barrel chest and accessory muscle use. Pursed lip breathing helps keep airways open longer to push out trapped air. Chronic bronchitis focuses on inflammation and mucus overproduction in the larger airways. Mucus glands enlarge and goblet cells multiply, producing thick sputum. Toxins paralyze and destroy cilia, crippling mucus clearance. Mucus stagnates, fostering frequent infections. The hallmark is a chronic productive cough, often worst in the morning. Over time, inflammation thickens and scars the walls, narrowing the lumen. Ventilation perfusion mismatch leads to hypoxemia and can drive pulmonary hypertension. The right heart strains, cor pulmonale, may present with leg swelling and fatigue. Smoking is the dominant preventable risk, responsible for most COPD deaths. Risk rises with pack years, packs per day times years smoked. Occupational dusts, chemicals, and fumes add substantial risk. Worldwide, indoor biomass fuel smoke is a major cause, especially for women. Alpha-1 antitrypsin deficiency is the key genetic risk. Consider it in young or never smokers. Age over 40, frequent childhood infections, and second-hand smoke also raise risk. Most patients have a mix, one pattern more dominant. One may be thin with hyperinflation, another has chronic sputum and infections. Nurses recognize both patterns, understand the damage, and tailor care. Progressive dyspnea shifts from exertional to limiting basic daily activities. Beyond lungs, COPD affects mood, independence, and social life. Diagnosis blends history, exam, and objective tests. Cornerstone, spirometry. Deep inhale, then fast, forceful exhale into a spirometer. We measure FVC and FEV1. The key is the FEV1-FVC ratio. Post-bronchodilator. FEV1 FVC less than 0.70 confirms COPD. Severity is graded by FEV1 to guide treatment and prognosis. Imaging shows hyperinflation, flattened diaphragms. CT detects bullae and wall thickening. SpO2 screens oxygenation. ABGs directly measure PaO2 and PaCO2. Check alpha-1 antitrypsin if genetic risk is suspected. Symptoms develop insidiously over years. Earliest sign, chronic cough, often productive in chronic bronchitis. Sputum color can signal infection. Dyspnea begins with exertion, then limits ADLs like bathing and dressing. Wheezing and chest tightness are common. Fatigue and deconditioning fuel a vicious cycle of inactivity. Severe disease may show cyanosis from chronic hypoxemia. Peripheral edema suggests cor pulmonale. There is no cure. Goals focus on symptom relief, slowing decline, and quality of life. Primary goal: reduce breathlessness, cough, and sputum. Most effective intervention to slow progression: smoking cessation. Prevent exacerbations: influenza yearly, pneumococcal per guidelines. Teach early flare signs and seek timely care, often managed with antibiotics and steroids. Pulmonary rehabilitation improves exercise tolerance and independence. Bronchodilators are foundational. Teach correct inhaler technique and spacer use. Short-acting for relief, long-acting for maintenance. Add inhaled corticosteroids for frequent exacerbations. Rinse to prevent thrush, acute flares, short steroid courses, and antibiotics when bacterial triggers suspected. Oxygen therapy for chronic hypoxemia. Target SpO2 88 to 92%. It reduces cardiac strain. For healthy adults, normal SpO2 is 94 to 98%. In moderate to severe COPD, target 88 to 92 to avoid carbon dioxide retention. Too much oxygen can suppress hypoxic drive, causing hypercapnia and acidosis. On NCLEX, 88% in COPD is safe. Avoid high-flow non-rebreather unless the patient is in distress. Teach oxygen safety and equipment care. Oxygen is prescribed. Don't adjust without orders. Pursed lip lengthens exhalation. Diaphragmatic breathing reduces work of breathing. Airway clearance techniques help mobilize mucus. Nutrition. Monitor weight. Encourage small, frequent calorie and protein-dense meals. Study tip. Build a COPD concept map. Branches. Pathophysiology. Emphysema and bronchitis. Risk factors. Diagnostics. Spirometry. Signs and symptoms. Medications. And nursing interventions. Question 1. What two conditions fall under COPD? Question 2. What slows COPD progression most? Question 3. What is the gold standard test?